So now we get to the secondary headaches, and they are important in two different ways. The most common or most important way is that secondary headaches usually lead to the diagnosis of the primary cause. So they're very important in the emergency room where the patient comes in. And headache is in fact the most important symptom that leads patients to an acute admission to a neurological department. And the other importance is that headache, even secondary headaches, can often be as a treatment problem by itself. So the requirement for proper treatment of the secondary headaches is also important. Because headaches are so common, and as we mentioned, 70% of the patients have, of the normal population have tension type headache, then many patients who come in with a suspected secondary headache have already had a primary headache before. But when they don't have that, it's obvious that a new headache occurring in close temporal association with the secondary cause is really a secondary headache and should be coded as such. If they have a headache before and this headache is made chronic, then the patient should have two diagnoses, both the primary headache that they had before and the secondary headache diagnosis. And the same is true if the primary headache is made significantly worse. That means at least a doubling of the frequency of the headache. So these are a little bit general aspects of the distinction between the primary and secondary headaches. We have general criteria now for the secondary headaches that, in contrast to previously, allow the diagnosis at the first patient encounter. And the problem is, of course, as we can see in this slide, how to define causality, because headache is so prevalent, and we need to be sure that it's actually caused by this the primary disorder. And the way we've done it is under C here. We say that there has been at least two of the following. Either it develops in temporal relation to the onset of the causative disorder, or it improves in relation to improvement, or it worsens in relation to worsening of the primary cause. In some cases, headache is characteristic of a primary cause. For example, thunderclap headache is typical of subarachnoid hemorrhage. And there can be other causes of evidence, for example, from laboratory tests and similar. So let's first look at headache caused by head trauma. In this case, persistent headache attributed to traumatic injury to the head. Unfortunately, very clumsy title, and I don't expect that it will be used very much. So probably people will continue to call it a chronic post-traumatic headache. But it requires trauma to the head, of course, and within 7 days after the head trauma, or after regaining consciousness, or after stopping medication that could slur the picture, the headache has to occur. So somebody comes with a headache occurring 2 months after head trauma, and they claim it's due to the head trauma, it will not be accepted. It has to occur within 7 days after the trauma. And since we are now talking about persistent headache, it is a headache that is continuing for 3 months or more after the head trauma. If it's disappeared within 3 months, we call it acute headache attributed to head trauma. And that's, of course, by far the most common. Then we have headache attributed to giant cell arteritis. occurring mostly in middle-aged to elderly people. They often have systemic symptoms and usually have a very high sedimentation rate and so on. We all know how to diagnose that, and it's a very important headache that should be suspected in all middle-aged to elderly people who start having headache and didn't have it before. Cerebral venous thrombosis is, of course, cause of headache, or said in another way, headache occurring acutely in young to middle-aged females. One should always suspect the possibility of a cerebral venous thrombosis. The evidence of causation is under C, as it is in all the secondary headaches. And it says that the headache has developed in close temporal relation to other symptoms of the cerebral venous thrombosis, or that it has significantly worsened or improved in parallel with the development of the cerebral venous thrombosis. It's one of the diagnoses that one always have to suspect in the emergency room with a new onset headache that's continuing for several days. Then we have this fascinating entity, headache attributed to reversible cerebral vasoconstrictor syndrome. It's usually a thunderclap headache or repeated thunderclap headaches, but it can manifest with other kinds of headache, and it can be triggered by sexual activity, exertion, Valsalva maneuver, emotional upset, and a number of other features. Nose drops, especially vasoconstrictor nose drops, and other drugs can trigger it also. And it's very important to diagnose and to treat, because it can cause cerebral hemorrhage and thus be quite a serious disease. Cranial dissection, cranial artery dissection is a usual cause of headache. It's usually half-sided on the side of the dissection. There can be some symptoms in the neck, and it's again the usual set of criteria that this headache is developing in close temporal association with the dissection. It usually resolves within a month, but there are now cases described that have persisted for more than 3 months, so it will be, in that case, chronic headache attributed to cranial artery dissection. Very important is, of course, idiopathic intracranial hypotension, and this headache is often severe. It's associated with high pressure of the cerebrospinal fluid, and it's difficult to establish causation by symptomatology alone. It's often accompanied by pulsatile tinnitus, papilledema, and there are now, but this is not included in the criteria here, but there are now a number of distinguishing features on MRI, which probably will go into a revised set of criteria in the future. The same is true for headache attributed to spontaneous intracranial hypotension, and also here the typical MR findings are not included in the criteria, but we have this clinical set of criteria, but they can't stand alone at all. They have to be substantiated by MR imaging. And of course, lumbar puncture is decreased. And then we have the headache that all our headache patients fear. They are afraid that they may have a brain tumor. And it's in fact very rare that headache patients who come to the physician have a brain tumor. Again, it's evidence of causation. Headache has developed in temporal relation to neoplasm. It's very difficult to ascertain. Very often it's like a crescendo headache getting worse and worse and worse over a few weeks, maybe 2 or 3 months. And very often it's paralleled by other symptoms of the brain tumor. The same is true with not only the onset of symptoms, but also the worsening of symptoms. And rarely we also see that headache follows the improvement of the brain tumor. That's mostly when we have already diagnosed the brain tumor and treated with corticosteroids. There are some features like early morning headache, which are typical because the intracranial pressure has been increased during sleep, aggravation by Valsalva maneuver, and as we said before, the headache is progressive and often accompanied by nausea and sometimes vomiting. That was a rapid trip through some of the secondary headaches. As I said before, the real importance is that they lead to the diagnosis of the primary cause. But more and more we now know that some patients continue to have headache after the primary cause has been treated. And this is a field where a lot of research, more research is needed because persistent headache attributed to something else has only been described in 2 or 3 different diseases. Thank you very much.